Welcome, everyone. We are thrilled to have you join us today for today's webinar. I am Ranjani Rangan from CharmHealth Marketing. Those of you who are new here, CharmHealth is an award-winning cloud-based EHR, practice management, and medical billing solution that helps healthcare organizations streamline their operations and maximize revenue. Many of our customers highlight that CharmHealth is one of the most intuitive EHRs they have used, with many customizable features to suit their specialty. We have tons of resources here to help you get started, and Dr. Bassi, our presenter today, is one such resource. Today, we have a special presentation from none other than Dr. Bassi. His presentation is titled "Maximizing Practice Revenue: Insights for Mental Health Practices." Practice owners. While many of our attendees today are mental health practice owners, this webinar is for any practice owner of pretty much any specialty. So we are so glad you are here to learn from Dr. Bassi, as he will explore the essentials of managing your practice billing, including setting fees, understanding the revenue cycle, handling denied claims, and more. Before I turn the time over to Dr. Bassi, let me tell you a little bit about him. He's a physician, double board certified in adult and addiction psychiatry, and the founder of Medical Director of TelepsychHealth, providing virtual mental health treatment across the United States, based in Jacksonville, Florida. Dr. Bassi earned his master's degree in biomedical engineering from Columbia University, graduated from the University of Michigan Medical School, completed his psychiatry residency at the University of Florida, and his addiction psychiatry fellowship at Northwestern University. Apart from his clinical work, Dr. Bassi is passionate about writing and lecturing on the use of technology in medicine to increase clinician efficiency and enhance patient care. His clinical interests include treating addiction and sleep disorders. Some fun facts about Dr. Bassi: he has been a longtime user of CharmHealth, as well as a wonderful advocate for Charm. And with his extensive experience, he has created his own training program that helps mental health professionals start their own private practice and more. You can check his program out at www.telepsychhealth.com/courses. And I believe he's offering a special coupon for those of you who'd like to get started with those courses. In addition to his clinical work and training programs, Dr. Bassi also writes wonderful blogs for many reputable organizations. He shares his knowledge with CharmHealth users on a variety of topics related to mental health and technology. Some of his articles include "How Would Digital Immortals Affect Psychiatry?" Ways wearable data can become incorporated into your EHR, and more. You'll find these blogs in the CharmHealth website, on the CharmHealth website under the blog section. You may also subscribe to our newsletter, where so you may get Dr. Bassi's blogs as they are released. So please sit back, relax, enjoy this presentation. There's a lot to learn, and we're excited to have you here. With that, I'm going to pass this on to Dr. Bassi.
Thank you so much. Thank everyone for being here, and thank Charm for inviting me and giving me the opportunity to speak. Hopefully it's going to be a very fun, enjoyable lecture, and I enjoy talking to people here and answering questions as well. And one reason that I love these topics, because I get to learn from other people too. And that's pretty similar why I went into medicine in the first place too, is to learn from patients, learn from other people. These concepts, although are geared more towards behavioral health clinics, I would say that's because that's what I know best. But of course, there are opportunities here for other people to also glean some additional information from them for family practice, for any type of practice, really. I try to be a little bit general about the topics that I talk about. So thank you, Ranjani, for giving me a good introduction there. And basically, I can almost skip this slide, but suffice it to say, bounced around quite a bit for training. I have a practice for the last 5 years. It's called TelepsychHealth. We're a general psychiatric practice, but we also focus a little bit on addiction, given that I completed my addiction fellowship, and we get a lot of referrals from individuals for addiction issues. We were primarily virtual, and now we have an office based in Jacksonville, Florida. It's a very small office, but it fits our needs perfectly for right now, given the majority of patients, they desire virtual work. And you can check us out if you'd like on our social media handle for clinician education is my own name, Bruce Bassi. And then for patient education, we're doing at TelepsychHealth across platforms. And my little passion project that I also started is called the Future Psychiatry Podcast, because I enjoy being part of the conversation about how technology fits into mental health care. And I think it's really fun to get to know CEOs and other co-founders, founders of various companies and kind of pick their brain about why they started their business and what the business model is, and how they're incorporating new features. So it's a lot of fun, and enjoying seeing it grow as well. So let's see here. I went over this. So yeah, we take insurance, just a little bit about the practice so that people can know, if they can relate to certain aspects about the billing components. So we do take insurance, major insurance companies, and I would say cash is very small component of our practice. I mentioned that I enjoy working in the B2B side of things. So I also try to balance my clinical time with talking about technology and consulting and coaching other individuals. And I still maintain my clinical practice. So my disclosures, I'm the only owner of TelepsychHealth. I'm also the medical advisor and blogger for Charm. And one thing I forgot to mention was that there's a coupon code CHARM50 that's available for a limited time for a private practice audit for everything I'm going to be talking about here, all these tips and tricks in one spot on the website. And you can get 50% off with that coupon code. It includes additional resources and commentary about everything I'm going to be talking about, because only really had an hour to go over everything. So if you feel like we're going over things too fast, and you can consider purchasing that and putting in CHARM50 in the coupon code at checkout. No other conflict of interest. Let me preface, this is a very taboo topic, one that we didn't really have very much exposure to in training. I think it's taboo because we're taught that we have a calling in medicine and you should be doing it for the most altruistic, virtuous reasons as possible. And if you're considering money as a factor in your decision making in medicine in regard to what specialty to go into, you're probably doing it for the wrong reasons. And so it almost feels a little shameful when you're going through training to say, hey, how are you doing? Like, how do you manage the coding? What are you getting paid for? You're not supposed to talk about that. And I think there's a lot of other attendees who could probably say the same thing, because they'll question, why are you in this if you're thinking about the money? So I think it's really important though. And there's something to be gained on the patients can also gain quite a bit if a practice is running well financially and is in financial good health. They actually do benefit from that as well. Say you have better staffing and you have better salaries for your staff, thereby your staff are happier, they're more engaged with the clients, they provide better communication. So there's actually a lot of positive benefits to talking about revenue and profitability in a private practice. It's not like all I'm going to say is you have to see more patients more quickly and try to get through a patient encounter in 5-10 minutes. Like, there are so many other components to just optimizing what you're already doing to give yourself even a better experience and improve efficiency in the practice in general. But nonetheless, it's fraught with a little bit of distaste, perhaps, when people talk about financial aspects of running a practice. It raises ethical concerns about whether or not the individual is balancing profit with patient welfare, and what are their conflict of interests? Why are they suggesting these things? but it is of my opinion that we can do both because we are talented individuals and we can understand, what decisions are we making that have a positive impact, what make it maybe have a neutral impact, and what have a negative impact. Because otherwise, there are going to be business owners out there who are going into essentially patient care, but for purely business reasons, and they probably don't have the exact same altruistic initial motives that we have as clinicians going into the field. So what better individuals to focus on the business aspect of a practice than the clinicians themselves? That's why I think that clinicians need to be better armed and better suited to be empowered to providing sound, efficient clinical care to patients. So yeah, there should be a new normal where clinicians own the practices and can also guide decision making in terms of business aspects of how the practice runs. And we can use certain guidelines of an ethical framework that guides us in terms of autonomy and beneficence, in terms of how many choices are we giving the patient when we do offer them an opportunity for a purchase. Are we giving them the opportunity to see another person for their lab tests, for their imaging, for their EKG, et cetera? Are we ultimately providing more good for the patient by giving them these options? Are we telling them what the risk benefits and alternatives are to these business decisions? So it's not as simple as just cutting the amount of time to see patients and just see patients more in your day, because that was probably the traditional model of the traditional thought. Our business plan, our business model revolves around seeing patients. The more patients you see, the more money you make, but there's a limited amount of time in your day and you can only go so far. You can only take that so far. So I I broke it up into 3 different buckets that I really conceptualized this by, in terms of 1, the revenue pertaining to appointments, your traditional business model. 2, other income streams that you can maybe incorporate into the practice itself or outside of the practice in terms of more B2B or advertising, et cetera. And then minimizing expenses as that, other core component to increasing profitability. So I'm not just going to be talking about maximizing revenue today, because I do think there is something to be said about minimizing expenses too. The more revenue you make, you make $1, a portion of that, 60% of that goes towards overhead, portion goes to taxes. But if you save $1, that's $1 saved and $1 earned. So it is, I think, a pertinent thing to talk about in this presentation. For the first one here, we're going to be talking about revenue for patient appointments, and I broke that up into in the appointment and outside the appointment. So within the appointment, what is there? Well, there's a few things that you can do: optimizing your schedule, utilizing telehealth, optimizing billing codes, setting your rates, how to set your rates, how to negotiate with insurance. And then there's claims processing and maximizing accounts receivable. So in regard to appointment scheduling, so you want to look at your schedule and figure out, is there ways that you can optimize it more efficiently? Can you eliminate the need to move to different locations multiple times throughout the day to cut back the number of times you're shifting modalities of care? Is there a way to optimize the time of day where it is best for your focus and concentration? I know for me, even though those evening times from 5 to 8 p.m. might be more desirable for psychiatry, it actually doesn't suit me very well for my focus and concentration. I'm not going to finish my notes. I typically do the majority of my notes during the session and try to finish up and then tidy them up afterwards. But if I were to see patients between 5 and 8 p.m., I'm not going to finish the notes, and I'm slower the next day completing my notes because I don't remember exactly what was said. So I found that I need to see patients when I feel I have the most optimal concentration. For me is late morning and also mid-afternoon. So I I recognized that, and maybe for me that led to um, little slow. I wouldn't even say slower growth, but a little bit more challenge getting patients into those slots if they're not 100% maximal, optimal desirability for patients. It's still, worked out fine, and it's best for me in terms of my long-term health and happiness. Um, and and in terms of optimizing your schedule, if you're doing telehealth and you're on the East Coast, for example, say you think lunchtime anywhere a patient is desirable, because doing telehealth you can see patients during their lunch break. If I'm on the East Coast and I add California and I want it to work at 3 p.m., then obviously um, a person in California can now see me on their lunch break, even though it's 3 p.m. for me. So one thing I would consider is adding another license in a state that is telehealth friendly that you can get, that would better blend and stratify the most desirable appointment times into your day. So that way you can meet the needs of your patients and also meet your own needs too, by having licenses in various time zones. You want to obviously reduce the potential for no-shows. And, when I'm going to the doctor, I always am mindful of this because I'm a practice owner. I want to see what is the best reminders, timing, and scheduling that works for me. And every patient's needs are different, so I would suggest reminders that go out on both or email, phone, and text. So all means of communication, so that you can meet their preference of the way that they want to be reminded. And I would say that you need to have at least 3 reminders, including at least one on the same day prior to the appointment time. And I have a policy where if somebody doesn't join the session within 2 minutes of the appointment time, then we call, text, and email, and do all 3 of those, because there have been countless times that we'll be able to reach them and remind them of the appointment time, rather than waiting there and too much time elapses and maybe they don't even remember, or that by the time they do remember, it's too late and you can't have the appointment anyway. So I reinforce that with all my clinicians, and it's been very, very helpful in getting them into the appointment. And you can consider a scheduling fee. This is probably hands down the most um, the best, most efficient way of reducing no-shows, is by either holding a credit card or charging a fee that can be applied to the patient's responsibility. And I think myself and many other clinicians would agree that that is highly effective for reducing no-shows. And how often, when you try to call the doctor's office, do they say, yeah, it's going to be a 3-month wait, the next appointment is in September for some highly desirable specialty? And the next sentence is never, do you want to be on the wait list? It's rarely is it, do you want to be on the wait list? And I feel, from my experiences, hardly any clinic ever utilizes a wait list. Maybe it's too cumbersome. It's perhaps it requires too much manpower or person power to groom it and kind of keep it up and keep adding and removing patients depending on whether or not they were seen. So that is one aspect that could be kind of off-sourced to technology to handle that component in your EHR system. But it is definitely a really easy way, because on any given week, we would have probably, I would say, 10 to 15% of either cancellations or reschedules per week. And so it boggles my mind that when I call and I want an appointment, those clinics aren't utilizing their wait list, because I know for a fact there's cancellations and reschedules and openings and whatnot. And so that's a very easy way to fill those spots. So the wait list we talked about. Oh, and then new patient slots on Mondays. For us, notoriously in our clinic, Monday morning, if you have an hour opening, it's very difficult to get somebody in within a 4 to 8 hour warning time. So a 4 to 8 hour of heads up. So that they really, we tried to avoid having any new patients on a Monday because for that reason, even if they give us what they perceive as 48 hours notice, if nobody is seeing it from Friday at 5 p.m. to Monday morning, I mean, it really doesn't give us much time to get a patient in for that Monday opening. So those are notoriously the hardest ones to fill an hour chunk of time. So then another way to maximize your schedule is by incorporating telehealth into your practice and maintaining that. One very big hesitation slash frustration with individuals, clinicians who are Medicare providers is that the Consolidated Appropriations Act initially was thought that it was going to have this very restrictive rule set in it where an individual needs to have an in-person visit every 6 months. However, there was an amendment or some sort of rule change that found they first extended it. So the COVID rules have been extended through December of 2024 before the Consolidated Appropriations Act comes into play. And also they have a stipulation there for an exemption if the patient and practitioner agree that an in-person non-telehealth service would garner too many risks and burdens associated with it versus an in-person service, then they can make that decision and document it in the patient's medical record that the in-person visit requirement shall not apply for that particular 12-month period of time. So that would be something that would just need to be documented in the medical record. And in that resources I was mentioning, I do have basically an appropriate way to write that down in the record that would describe that. Optimizing billing codes. So this is another topic where there's say you are doing the work, you have a patient who is they have probably 2 or more unstable diagnoses, but if you only document one and you don't document appropriately, you're leaving money on the table and underbilling, which they say is also fraud. But so you want to make sure that you're not underbilling. It's actually easier now with the new changes in 2021 to meet the criteria for 99214 and a 99204, because the criteria for that require one or more chronic illness with exacerbation, progression, or side effects of treatment. So it's very easy a lot of our patients have a chronic illness. They're coming to us with exacerbation or progression. And another setup that would meet that criteria for 99214 would be one undiagnosed new problem of uncertain prognosis or one acute illness with systemic symptoms. So it is very easy to meet the criteria. You just have to make sure that your documentation should be standardized, where the language that you're using, I think by default should default to using the 99214, because that does suit a lot of our patients. And if you feel that the visit was so straightforward, you can eliminate that documentation from the template and code for the 99213. But in that case, I mean, if you're doing it this way, where you know that you at least may meet the criteria for 99214, in the event of an audit, you'll never have any issues because you've already preemptively thought about what the criteria are, and it's pretty well baked into how you document, and that's second nature to you. If you do use the 99204 for a new patient visit, you can bill for the 90836. I actually went years without even knowing that until somebody else told me that. And with that combination of those two codes, sometimes it can lead to higher reimbursement than 90792, which psychiatrists use. stipulation with documenting for a therapy add-on code is that some insurance companies require you to document not only the quantity of minutes spent, but the exact times of the session itself that were spent in psychotherapy. So make sure that for compliance purposes, you're also including the exact clock times of the therapy itself, in order to utilize that add-on code appropriately. And just as a tip for psychotherapy billing, so you're documenting start and stop times, type of therapy done, progression made, goals set, and whether or not you spoke to or collaborated with the patient's current therapist. So those were all of the criteria that were asked of me during an audit from an insurance company. So from there on, that's how we learned to document for psychotherapy. Some would say that if you do bill for psychotherapy at a higher incidence than what the general population of your peers does, then you are at a higher risk of audit as well. But typically you would get a warning letter sent out. And I understand that certain insurance company actually just blanket sent out a warning letter to all clinicians about this. But if you're billing appropriately, there's nothing to worry about.
Dr. Bassi, there's a question here.
Okay.
It says, how do I charge a patient for a no-show without writing an encounter note? And in parentheses, it says, can't write an encounter note since they didn't show up.
Okay. In Charm, I can only speak to Charm. I don't know which EHR you're using, but in Charm, we do create a new encounter, and then we enter a 999 code, which is our own made up code that's not covered by insurance. And we have a description that says no show, because the way I was trained was that you should still document your efforts that were made so that those are in the medical record, that you tried calling them 2 to 3 minutes afterwards, they didn't pick up, whether or not you left a voicemail, whether or not you texted them, whether or not you emailed them. And then we say, we'll remain available for follow-up appointment. And that's typically how we handle it. We just don't submit a claim for it. We generate an invoice that goes to the patient, but we don't submit a claim for it. So that's how we handle it. Does charging a fee for a no-show legally create a doctor-patient relationship? My understanding of doctor-patient relationship, which is a good reminder to me that I didn't mention a disclaimer for the advice here. I mean, I'm not a lawyer, so any sort of legal advice should be pertinent to your situation, and that can only come from your own lawyer who knows your exact situation. But my understanding was that if you engage with the patient and you take a history, you get to understand what their issues are, and you're giving them specific medical advice specific to their situation, that has created a doctor-patient relationship. But if the patient pays to hold a session, they're holding that session, but you haven't actually had the appointment yet, then a doctor-patient relationship hasn't formed yet. I'm always hesitant to do like a free consultation, which a lot of therapists do. I think that could be construed as forming a clinician-patient relationship, and I would be a little bit more hesitant about that. With the new patient no-shows, everybody, you have to make your own personal decision about whether or not any of my suggestions here might not be suitable to you because of the potential backlash that patients can give, understandably. So we have found a balance where we have a bit of flexibility. We say that there's exemptions for times of emergency or sickness, and we often, pretty much all the time, don't charge for a new patient appointment. It's not worth it to us to have such a dissatisfied individual at the end of the year. I don't think it makes that much of a difference when, we have a number of other mechanisms there to try to compensate for that patient's no-show appointment for the initial visit, that we don't charge them the full amount. do a lot of practices charge the full amount? Absolutely, yes. But yeah, definitely psychiatrists charge the full amount. And I've even read that you can charge for greater than your cash pay rate because you can charge for the administrative burden of setting them up for that appointment. So that's a good question because it just, it involves the conversation of like, yeah, these are business decisions, but there's also this human element to trying to be kind and altruistic, like I was mentioning at the beginning of the presentation. And you have to just consider how strict you want to be on certain ones of these. Optimizing billing codes. These are things that a lot of clinics, they have already incorporated. So they're doing standardized screening instruments, but they're not billing for them. So I'm not telling you to go, you don't even have to do anything different, but otherwise optimize your billing codes. So using these screening codes, and one of them being the 96127 with the modifier 59, that would be appropriate for a psychological screening test, such as the PHQ-9, PHQ-4, GAD-7, PCL-5, etc. They get reimbursed about $5 each, and you can use them up to 3 times per encounter, per data service. So, people often, they get really annoyed about credit card charges. When I was posting and marketing this presentation, somebody mentioned that they want to get rid of their credit card charges, which is like kind of a cost of doing business, is the way a lot of people see it. But if you have the opportunity to get reimbursed for 3 of these 96127s, that already makes up for that credit card charge. And how many of us, maybe 5% of clinicians, are actually utilizing this for a screening intervention, which are already on our initial consent forms, or they're on our intake forms. If you're a family practice doc, or somebody in family practice or addiction psychiatry, or even general psychiatry, you can do the smoking tobacco use cessation counseling, at least 3 minutes. You need to have used a screening instrument and also counseled them on methods, skills for cessation, their willingness to quit, potential medication options you talked about, resources provided, setting a quit date, setting a follow-up that you're going to, ask them about that again. And that's another $30 there, typically from Medicare. And then there's 99408, which is for alcohol substance screening. It has to be at least 15 minutes, using a commonly used standardized screening like the DAST or the TAPS or audit for alcohol. And for that one, and the other one you would use a 25 modifier, because those are used with E&M codes, and the 59 is used for non-E&M codes. So this is also like a pretty nebulous topic of how to set rates, how to negotiate with insurance. Every insurance company, from my experience, has a different approach to this. Some of them, they don't negotiate whatsoever, and you're making the same rate as 100% of other individuals and also all of the hospital systems, and it does not vary one bit. And then there's others that, you talk to your network manager, and some years they're very generous and they're like, oh yeah, we can accommodate that, and tell us your rates. And then others, they say, yeah, this was a rate increase that we gave everybody and we'll apply it to yours. So you don't really know unless you don't ask. Our typical frequency has been about every 2 to 3 years we'll ask. But I think only one time have we been told you asked within a year ago, and I think that's why we stopped doing it every year. So I think they'll only consider it if it was within the last year or more than the last year. Obviously, there's a reason that a lot of psychiatrists in California are cash only. It reduces a lot of overhead. Is it the best decision economically speaking for the entire populace? That's a whole nother conversation. But if you have the geographic location that is suitable for a cash pay practice, and you have the referral streams for that, then that's another option. I am just putting out ideas out there of what works for other practices. Is if you're first starting out, I would not recommend doing it this way because it would be very, very slow growth and you'll have a lot more overhead than you would revenue. Um, uh, but that's something to consider. How to set your fees. You want to see, are your fees competitive? Can you bring them more in line with the geographical average? Do you offer anything that other practices don't offer that you could potentially rationalize having a higher fee for? So how to set your fees. What I did when I was starting out is analyzing others' rates. They are often on their website, some are not. Thinking about what your operating costs are, which is difficult when you're first starting out. You don't necessarily know your operating costs, but you can get a pretty good sense of how much the technology piece is going to cost over a course of a year, how much your labor is going to cost if you have a virtual assistant. Then you take what the amount of salary is that you want, add in your operating costs, divide it by 12, and that's the total amount that you need to make per month. And you can divide that by the amount that you were considering charging, and that's the number of patients you need to see per month. Or you can say, what is a reasonable number of patients I can see per week, and then work it that way, the calculation that way, to see what is the charge that you need to make. Another component is claims processing. Obviously, we have a little bit of attrition of revenue from our funnel there, and this is one component of the cycle. So billing cycle means the patient incoming, collecting their information, seeing the patient, generating claims, scrubbing the claim, sending it through the gateway, monitoring for any sort of errors that come back, checking to see if it was accepted, evaluating the EOB for any sort of underpayments, and then collecting the remaining afterwards, and starting the cycle over again. Some insurance companies have their portals now on Availity where you can submit a request for reprocessing a particular claim, which I don't know if that's necessarily going to add a lot of more efficiency, because say it just feels a little bit easier in terms of more certainty that that's actually going to happen when you talk to a person. So our practice, we've been a little bit hesitant to use their portals for those reasons, but I don't know, maybe when they become more commonplace, people would feel more comfortable with that. Handling denied claims. I think I'm not going to go into very much detail on this. Really, I think that's probably a little bit out of the scope of what I want to talk about. Drafting an appeal. And once you do one, you'll get to understand what the insurance company wants and needs, to basically the demographic information. And we've had a lot of appeals accepted, and we've had some not accepted, but we've had the appeal to the appeal accepted, and they often need to be faxed in. You should include the reference number of when you call to get the benefits. We've had many instances where they honored those benefits. We have had instances where they said, "Hey, yeah, great that you got the reference number, but we gave you the wrong information. We still need to claw back the amount." So yeah, that's happened too, but it definitely helps to have the reference number from when you called. And we also print out the benefits from Availity and have them stored in the patient's chart as a PDF. And we're going to go into topics outside the appointment. Thinking about charging for ancillary tasks that you do, portal message fees, removing or remote patient monitoring, psychological testing, optimizing the collections process from the patient, eliminating causes for refunds, engagement for follow-up. So the idea behind this is to get paid for what you're already doing for free. Every other profession, they charge for their time. I'll never forget this. I CC'd a lawyer, and she charged me for being CC'd on that email, and she didn't need to reply. There was nothing that came of that other than reading the email. So she charged me for 1/10 of an hour or 6 minutes at her rate. And I was pretty dumbfounded to find that invoice in my mailbox later on. But for some reason, clinicians were the only ones who feel like we should be able to do paperwork, prior authorizations, answering portal messages, rescheduling, all these things don't deserve a charge. So that does add up. There's definitely a lot more administrative burden there. I remember initially I didn't charge for paperwork. I didn't even know that was a thing. And I talked to my mentor. He's like, yeah, you just charge for it. And I find when I'm charging for it now, I'm not just trying to get it over with. I'm, doing it well and thoughtfully and more engaged in it. But for paperwork specifically, we default to trying to get it done in the appointment. I think it's just way less miscommunication, more clarity. The patient's happier about what is put on the paperwork, and that there's not going to be a lot of back and forth there because they're helping you go through it. So that's typically what we try to do. And then if it's something that needs to be done outside of an appointment, then we'll charge for it. Late cancellations. You have to decide what your policy is. Is it going to be the same day? It's going to be, if they cancel within 24 hours, 48 hours. I would say anecdotally, what I think is average is 48 hours, 48 business hours. It would be the full charge. I've found that hospital systems in large practices, they'll have like a $25 charge, something nominal, but a private practice would typically be the full amount of a clinic visit. We always have in there no show unless due to sickness or emergencies. It's just like it diffuses the whole situation when they're thinking that somebody who to $100 to a certain person, $100, $50, that's a lot of money to them. And if they're worried that because they were ill, they're going to have to get charged that amount, they call in pretty distraught. So we do let that slide in those instances. For us, I don't think that's really worth it for our reputation to uphold. So we have a bit of flexibility there. And then, for late fees, there is a little bit of state variability there. What is a appropriate late fee? And it's, I think, fairly hard to navigate the resources online for that. I would just say talk to your lawyer or accountant to see what is a legal late fee that you can charge, or go to your local hospital system and look at their invoice that they send you. It's probably written on there. But yeah, it's not well documented in the state statutes. You mentioned 3 times per encounter. Does that refer to each individual patient visit? I think I was mentioning the reminder should be 3 times per encounter. Yeah, so yeah, that would be, probably at least one in the first day, the day of the visit, and then one the day prior, and then definitely one at your cutoff for when is the late cancellation. I remember that was the reason somebody got mad at us. We said we wanted 48 hours notice, and we gave them probably eight months of heads up. It was on all of our scheduling reminders. It was everywhere that the no-show rate, the charge was going to change to 48 hours rather than 24 hours to help with that Monday thing I was talking about. And they said that we didn't give them a reminder at 48 hours. So now we have one at 48 hours as well. Okay. portal message fees, I mean, if you are any sort of clinical forums on Facebook, like this is getting super common. Cleveland Clinic does it. All of the major hospital systems are doing this now, where they're charging for portal message fee. It's this. Oops, this one reimburses 41421 reimburses $16 if it's between 5 and 10 minutes. Whether or not this is suitable to your practice is up to you. I mean, it could potentially discourage people from reaching out because they have to pay their portion of this charge, whether or not that's a copay or their co-insurance. It could disproportionately affect lower income individuals because that's obviously a lot bigger percentage of their income. And could add like a layer of distrust where, like I had that experience with my lawyer, kind of felt like a little nickel and diming. It didn't feel like the most open lines of communication. So, and then there's a bill for coordination of care. If you coordinate with care with another clinician, 99484. There is a requirement for the 99421, this portal message fee, that if it's within 7 days of an E&M service previously, then it has to be for a new problem and the patient must have initiated the issue. The message, and if it's 8+ days from an E&M code, then it could be for an old problem or new problem. So that's another factor to consider for the 99421. Remote patient monitoring, if you have been around alive the last year, you probably gotten like a bunch of spam calls from at least a few remote patient monitoring programs that want to basically provide you with the service where they send the devices to the patient and they're going to handle billing, and they take a chunk of the revenue from that. So this has become a pretty booming thing, as you can see from this graphic here. It's just becoming much more common. And whoops. And there's various codes down here for the setup and patient education of the device, the 99453. And even for the 99453, they have to have used it for at least 16 separate days of readings within a 30-day period. The 99454 is for the remote monitoring of the parameters and includes the supply and use of the device. And that reimburses roughly $50, and you can use that once per month. And then the 99457 is for the management of the patient up to the first 20 minutes. So you have to, the clinician, a qualified healthcare provider, has to engage with the patient. I think it could be also electronically, and incorporate that data into the management of the patient. And that's used once per month. And then there's psychological testing for the behavioral clinicians out there. So there's 3 different tests. So there was that screening test also that I mentioned on an earlier slide, and then there's 3 test codes, 2 for administration of the test, and then 1 for test evaluation. So these codes have been kind of the bane of some psychologists' existence, because it's way different than it was 4 years ago in terms of ease of reimbursement for these from insurance companies. There's a lot more clawbacks now, and there's a lot more questioning of medical records to document the medical necessity of these codes. In order to document medical necessity, you need to say whether or not there was a treatment that failed or the diagnosis had worsened. And also document the number of tests performed, the rationale for the tests, your findings, your interpretation, your care plan, the amount of time spent with the patient, and the amount of administrative time that you've used with the test itself. One thing to point out here is that the 96138 can be administered by a technician, and there's no like accepted definition of what a technician is or what kind of qualifications the technician has. But they can administer this test, and they need to have spent at least 16 minutes with the patient. And that does reimburse for $33 for that one. Okay, so take this question here. How do you, can you explain how to build in the cost of admin work? Most of my clients are insurance clients, and so I don't feel like I can do much with the cost. So obviously admin work is a part of it. I don't know if you were in the presentation there's two components that I mentioned in the previous slides, one for billing for messaging, and then another one for billing for paperwork or other ancillary types of things. Another suggestion I would have is setting off a block of 15 minutes where or not 15 minutes, but say an hour, where you can do quick check-in appointments, and you can have add-on appointments that day during that block of time for messages that you feel rise to the level of needing an appointment. And so what I would typically do is text the patient through our EHR system and say, hey, are you available at 1 o'clock for a brief appointment? And I use the word appointment so they know they're going to get charged for it. And then I would address the message in the appointment with them. So that's how I handle that. So optimizing collections process from the patient. As you get further and further away from the appointment date, the rate or chance of collecting on it just goes down and down. The chance that their phone got turned off, they have a new phone, they moved away, they're no longer interested in contacting you. It just decreases. Maybe the credit card actually is no longer in service. Maybe the credit card got blocked. There's a lot of different reasons that you can no longer collect from the patient as you get further along. So it's in your best interest to be able to automatically charge the patient after their appointment takes place. And you want to, a lot of the times we're given a credit card of somebody else that's not in the name of the patient. So they're holding somebody as a financial guarantor for their visits. And if that happens, you can't argue a chargeback from the insurance company if you didn't have anything signed from that financial guarantor. Therefore, you need to get that financial guarantor to sign that they're responsible for the visit costs and any sort of other ancillary charges that come with the visits for this person. If you do get a chargeback from the credit card company. For people who can't pay, we've previously, for the first 2 years of the practice, used a collections agency, but our success rate with that was pretty low. So what we've done alternatively, instead of using collections, is just developing a payment plan, getting that in writing, and having the patient basically they're coming up with the payment plan structure and amounts, and they're signing that they agree to that. And so it's generated by the patient. The specifics of it are generated by the patient or driven by the patient, and then they're agreeing to it, and they're much more likely to pay. So chances of collecting on that payment go way up from 0%, which is what our historic rate was with collections agencies. There are some third-party vendors out there that can automate collections if you find that this is fairly burdensome to your staff. For engagement with follow-up, we're not saying, I'm not saying to pester patients to tell them that we need to drag out treatment for the next 2 years. I'm saying patients who are needing treatment, they probably got busy with work. They canceled the appointment one day and they just forgot to reschedule. And other patients who who maybe are interested in ongoing care, but they get lost to follow up. So there's a number of patients who I think is very easy to they're still under your care because maybe they're taking a medication or you're the only clinician that they've seen. So therefore, they're still, I mean, a lawyer would argue they're still under your care. You should be making sure that once they stop engaging in treatment, you formally discharging them from the practice. That's what a lawyer would say. I don't know if all clinics do that, but you're supposed to have a clean break there from discharging them from the practice. One thing you can do is generate 2 reports and figure out to isolate and identify these patients. So you can run a report of who has been seen more than 3 months ago. So you want to generate a report of all those patients, and then you're going to generate a report of who's scheduled in the future. And then you're going to use a formula in Excel. You can do there's a match formula to see if there's a match there and identify the individuals who are seen more than 3 months ago, but also not scheduled for follow-up. And then, isolate them. Should we send a discharge letter? Should we send them a reminder to get them in? We also use an opt-in feature on our intake forms now so that they can opt into our newsletter, clinic newsletter, for important announcements. Constant Contact now, they offer a BAA, they're HIPAA compliant. They're much less expensive than PowBox, which is another one that we use. I have referral codes if people want a discount for those. So now we have about a 50% opt-in rate when people do their intake forms, and then they're on the email reminders. We don't send out very many, maybe 3 a year, but I think it's enough for big, announcements, reminders in January. Hey, your deductible reset, that kind of thing. What are other income streams? So, you can think about physical products. A lot of offices do this, especially dermatology, cosmetology. There's a reason they do it. You can also be a prescription vendor for physicians. You can dispense prescriptions if you wanted to. You could probably do controlled substances too, but it's easier to start off with not doing controlled substances. You can create a digital product and ask yourself, what do you enjoy talking about, teaching about, what excites you, what are you best at, and create that and sell it. You can add ancillary services like B2B coaching. A lot of therapists are doing this now. I'm doing consulting, speaking opportunities, clinic services. You could add a diabetes or weight management program, IV infusion therapy. And physicians, you can do the dispensing like I talked about, lab testing, imaging, EKG, or have a supervisory relationship, bring on board a PA or an NP. And we're going to talk about minimizing expenses. Maybe I'll take a question now. I don't think chart provides a report that shows patients who are not scheduled for a follow-up. So, Haley, I don't know if you were here for the way I described doing it for two. You have 2 lists. You export people. There's a way to export the list of people who have seen more than 3 months ago. And then there's a way to export the list who have a follow-up. And then you can, or you can even export all the patients you've seen. And then you have 2 columns. And then you use a isMatch formula within Excel. And you just do the formula once and you drag it down. In the resource I have, I put the formula in there on my website under the telepsychhealth.com/courses. It's in that resource, Excel formula. You can just copy paste in there. And it will give you basically say false for all the people that you need to contact because you saw them and they don't have a follow-up scheduled. And it will say true for all the people who do have a follow-up scheduled. Okay, so labor costs. So according to the AAFP, Family Practice Physicians, 60% of the practice's revenue goes to overhead. Of that 60%, 26% of that 60 goes to labor costs of support staff. On average, each physician in the family practice have about 5 support staff. So obviously that's not the case for therapists, but it goes to show that a virtual assistant paying them, I don't know, $45,000, $50,000 a year is way more expensive than say a piece of technology that maybe costs $1,200 a year. So if you can do something that automates a process and only costs you $100 a month, then and that prevents you from having to get another virtual assistant, then that obviously pays for itself, because the chunk of the labor costs are very expensive. So that's why I put this one first in terms of what you want to identify in terms of efficiencies, is because these labor costs for support staff is so high. It's usually the first major kind of expense when somebody is growing. They're going to hire an assistant, virtual assistant. You want to identify what your staffing needs are at times and see, can they cut back their hours from being full-time to part-time? What are they spending their time doing? What are their pain points where they're getting held up doing a lot of redundant tasks? And can those be implemented with maybe a CRM rather than using a spreadsheet or just manual labor for the spreadsheet itself? And scrutinize the cost effectiveness of certain services. For us, we've been contacted by offshore virtual assistants, and it would probably cut costs. I think that it's worth it to us to have in-house billing and front staff so that they can handle patient inquiries right off the bat, and the patients seem a lot happier, and they enjoy the level of communication that we have, rather than having like a call center agency handling all the calls and just giving us a message. It seems like there would be a lot of back and forth there. Then building overhead is the next biggest cost. So if you're virtual, you don't have to worry about this slide. But if you do have a building, think about, can you maybe do telehealth and rent out some other therapist's office when you need to go in person? There are some directories online where you can post open office space for other therapists to find, so that we can all kind of collectively work together. If somebody needs office space, you can match them with an office that has rooms open and they're just sitting there and they're not using any revenue. You can, or if you have an open room, you can consider adding a biofeedback station. You can add a TMS station. You can do ketamine in that room. You can do virtual reality therapy in that room. There's a lot of in-person services that you could potentially grow in a room that's not being utilized if you do have open extra space. But yeah, those are my thoughts on overhead. And then in terms of technology, believe it or not, is 2% of revenue, but this was from an article from probably 15 years ago. 10 years ago. I'd imagine that it grew more substantially than 2%. But you can always think about how to economize on tech services by incorporating all-in-one services or automation systems like Zapier. Utilize AI to help key up redundant tasks with letter writing, message responding, etc. I think this is something that's going to grow quite a bit in the future. And then identify assets or features within your EHR system that facilitate automation, like automatically faxing notes after you sign a claim or sign a encounter, generating invoices automatically, claims, reminders of patient consent forms, outstanding bills. That used to take up quite a bit of our time too. In terms of legal and insurance costs, these can be quite high when you're first starting out, and I would recommend, I mean, sometimes you can't do anything about the premiums themselves other than shop around and work with a broker to try to get the best price. But I mean, you want to work with somebody reputable. So there's only so much you can really do there. You can always ask them about discounts, ask them for a part-time discount if you are working actually part-time instead. Utilizing their resources and helpline whenever possible. My malpractice people and my EPLI insurance, they have really good resources that I'm often turning to that would save me $300 to $600 because I don't have to actually engage with a lawyer. I can actually just go to their resources first. If you're not taxed as an S corp, you might want to ask your accountant if you can be, because it would save you quite a bit on self-employment taxes, because all the pass-through income after you pay yourself a reasonable salary for somebody of your position, all of that doesn't get taxed with self-employment taxes like Social Security and Medicare. This last one, bullet point 4, is a little controversial. If you talk to an accountant, they might scream at you. But if you're thinking about other options, I'm just giving you options. There's IRS section 280A, section G2, where you can rent part of your home to a corporation, and that corporation can be your own corporation. So for monthly shareholder meetings, you can do this up to 14 days per year. For shareholder meetings, board meetings, you can rent out your home at an average rate that a hotel would cost, and you can actually do your due diligence and document that you've received quotes from 3 nearby hotels, and you're taking the average of those, and you're whether it's $600 to $1,200, and you as a homeowner doesn't need to report this as income because you're allowed up to 14 days worth. This is called the Augusta rule, but I would definitely talk to an attorney about that. Marketing expenses. So obviously reviewing for waste and inefficiencies. And that means just you have to figure out what works best for your audience. Everybody's product, audience, geographic location, their approach might work a little bit differently. So you just have to see what are your best channels and focus your energy on that and remove the least effective channels. And that goes for either social media or paid per click ads. So you might want to consult a marketing strategist to avoid investing too much money too early. Because if you don't know what you're doing, I mean, it's just easy to kind of just throw away money in terms of ad spend. You want to identify reasons for funnel leakage. And even if you don't have a true funnel necessarily, even if patients are just calling, they say they call, they're really interested in an appointment, but they don't follow up, you can coach your front staff to engage a little bit more with the caller to see what their needs are, what are they interested in, and that could somewhat help you determine where are you losing potential interested patients / customers, clients. And there's plenty of free marketing opportunities out there, i.e. your own patients through word of mouth referrals with a nominal amount that doesn't need to be reported. That wouldn't break the not the Ryan-Haight, but the Stark law rules, because if it's under, I was told under $10, you're in the clear. So it's a small, very nominal amount for a gift card. You could put that in your intake paperwork and reminders and things like that. There's also a lot of free directories out there for college students, for telehealth agencies, and you can get listed in those. And then your colleagues themselves, you probably have a lot more colleagues than you can even remember, and they might not even know you have a practice. So there's probably missed opportunity there that you can reach out to them and engage with them and let them know. And even if you're not necessarily like totally up, like your practice is even up and running yet, you can still start to let people know about that. that you're working on it and that you'll be seeing patients in September or whatnot, so that you're staying engaged with them and nurturing that connection.
Thank you, Dr. Bassi. That's really nice. I see a comment here by an attendee. Very helpful, extraordinarily helpful. Thank you. And there's a question here. Any advice for residents, PGY 3/4 transitioning to PP?
Yeah, I mean, that's a good question. I would say start thinking about how the outpatient program is run from a business perspective. Who is working, like who are the staff and what do they all do? Because they all have a particular role, and you're going to have to find ways to hit all of those roles with just one person. It's going to be you initially. So you're going to be the filler, the coder, and think about what they do. And if you have time and opportunity to pick the brain of the coder, see what are their issues that they're running into. Just try to understand their workflow. What are they using to organize themselves? And just get those ideas out there and think of the outpatient clinic like a business itself. You've done a very good job, working on the clinical aspects of things. And now it's time to think about how you're going to get your private practice launched off the ground. And second, I would say find a mentor. On Facebook groups, there's a little bit of transparency, but people don't tell you everything online. Obviously, if you're a judgment, they don't know you. But find a mentor who you trust, who they can tell you. I remember my mentor was Ryan Raffian. He's a Gateway Medical Director. He's just like, yeah, you charge for paperwork. Everybody charges for paperwork. And before that, I thought it was so foreign to charge for paperwork. And now I just feel like it's like, why didn't I just think of that earlier? I spent weeks stressing about this, or maybe months, like thinking about how I'm going to fit this into my day, when there was a very easy fix that I could have just asked a mentor. So there's that. And I think, not to put a self plug out here at all, but my course would actually probably save you money with a lawyer, because you'd be more efficient in talking to your lawyer. You know what to ask them, and you can utilize their time more efficiently. So while the course, there is a charge for it, and it would probably save you money down the road, because you don't know what you don't know. So I have over, I think, 53 lectures, 6.5 hours worth of material. I think my PDF that I put together has about 200 pages of various topics and tips and tricks and things like that. So if you're first starting out and if you're a resident, I think it would be super helpful. It was the one that I wish I had back when I was starting out.
Dr. Bassi, do you provide mentorship for residents and private practice newbies? Could you, I have a question here, and actually that was my question for you as well. I know you do at some level, right?
Yeah, I do. I know, there's financial and time constraints, but I would be definitely willing to talk to you during my office hours. You can text me. I'm much better with texting than I am like with setting up appointments, just because I'm busy, but happy to text, whatnot. You can email me, Bassi at telepsychhealth.com. Come to my open office hours, which, if you buy the course, you don't buy the course, that doesn't matter to me. You can still come to the office hours. And I can field some of your questions or concerns there. It's at 4:30 Eastern on Thursdays.
Thank you, Dr. Bassi, for generously spending your time today. And Dr. Bassi is also, as he mentioned, provided a code that'll give you a discount on his training program, the audit training program, the CharM50. This will help mental health professionals. Is this for the starting your private practice? No, this is for the audit.
Different.
Okay, different one. Yeah.
Yeah.
So I have added that code in the chat window once again, and we invite you to subscribe to the CharmHealth newsletter to stay up to date with the latest news and trends in healthcare technology and about CharmHealth, and including Dr. Bassi's insightful blogs on mental health and technology. And you can get a free account with CharmHealth by logging into the www.charmhealth.com website to check out CharmHealth if you are new to it. All right. Well, thank you all once again for joining in, and looking forward to seeing you at our next webinar. I really appreciate it.